Welcome. Today we're going to delve into a fundamental area of human anatomy, the female external genitalia. This region, collectively known as the vulva, is often misunderstood, yet a clear understanding is absolutely critical for any student in the medical and health sciences. Whether you are pursuing a career in nursing, medicine, or allied health, mastering this topic is not optional. It is a cornerstone of providing competent and compassionate care. This area is central to reproductive health, sexual function, and overall well-being. It is our responsibility as future and current healthcare professionals to approach this subject with diligence, respect, and a commitment to thorough knowledge. The term vulva refers to all the external genital structures of the female reproductive system. It encompasses everything you can see on the outside, from the Mons pubis down to the perineum. Think of it as the gateway to the internal reproductive organs. Its functions are diverse and vital, playing key roles in sexual arousal, urination, and childbirth. A comprehensive grasp of its anatomy allows for accurate diagnosis, effective treatment, and sensitive patient communication. Without this foundational knowledge, we risk misinterpreting symptoms, overlooking serious conditions, and failing to provide the standard of care our patients deserve. Our journey will be methodical. We will start by identifying each component of the vulva, one by one. We will explore the outer protective layers, the labia majora, before moving inwards to the more delicate labia minora. We will then focus on the highly sensitive clitoris, a structure dedicated purely to pleasure. Following that, we'll examine the vestibule, an area containing the openings to the urethra and vagina. We will also discuss the important glands that provide lubrication. This step-by-step approach ensures that you build a solid and logical understanding of how these parts are arranged and how they function together as a cohesive unit. Beyond just naming the parts, we will explore the intricate networks that sustain this region. We will trace the pathways of the blood vessels, the arteries that deliver oxygen-rich blood, and the veins that carry it away. We will also map out the complex nerve supply, which is responsible for the diverse sensations experienced in this area, from touch and pressure to pain and pleasure. Understanding this underlying physiology is what elevates basic anatomical knowledge to true clinical competence. It's the difference between simply knowing what a structure is and understanding how it works and why it matters in a clinical context. Let's begin. Let's start from the outside and work our way in. The most visible structures are the Mons pubis and the Labia Majora. The Mons pubis is the rounded, fleshy prominence located directly over the pubic bone. It is formed by a pad of fatty tissue and, after puberty, is typically covered with pubic hair. Its primary function is protective. This fatty cushion acts as a shock absorber for the pubic symphysis, the joint connecting the two halves of the pelvis. During intercourse, it helps to buffer the impact, safeguarding the underlying bone from trauma. It is a simple but important structure, providing the first line of defense for the delicate anatomy that lies beneath it. Extending downwards and backwards from the Mons pubis are the Labia Majora, which translates from Latin as larger lips. These are two prominent, elongated folds of skin that enclose and protect the other, more delicate external genital organs. They are the anatomical equivalent of the scrotum in males. The outer surfaces of the Labia Majora are pigmented and, like the Mons pubis, are covered with pubic hair after puberty. This skin contains a high concentration of sebaceous and sweat glands, which help with lubrication and thermoregulation. The labia majora provide a significant protective barrier against pathogens and physical friction for the inner structures. The composition of the labia majora is primarily adipose, or fatty, tissue, and a thin layer of smooth muscle, which gives them their full, fleshy appearance. They unite anteriorly at the Mons pubis and posteriorly just in front of the anus, forming a ridge of tissue called the posterior commissure. This entire structure serves as a robust protective frame. When a woman is standing or has her legs together, the labia majora typically meet in the midline, covering the labia minora and the openings to the urethra and vagina. This natural closure is a crucial part of the body's defense mechanism, helping to maintain a stable internal environment. Understanding the labia majora is clinically relevant. For example, they can be affected by various dermatological conditions, such as contact dermatitis from irritants or allergens in soaps and detergents. Cysts, known as sebaceous cysts, can also form within the glands of the skin here. During childbirth, this area can be subject to stretching and, occasionally, tearing. As healthcare professionals, being able to identify and assess these structures accurately is the first step in diagnosing and managing a wide range of common and sometimes complex conditions affecting the vulva. A thorough visual inspection is often the start of any gynecological examination. Situated just inside the labia majora are the labia minora, or smaller lips. These are two thin, delicate folds of skin that lack the fatty tissue and pubic hair found on their larger counterparts. Unlike the labia majora, the labia minora are hairless and contain a rich supply of sebaceous glands, which secrete sebum to help lubricate and waterproof the skin. Their size, color, and shape can vary significantly from one individual to another. This variation is completely normal and is an important point to convey to patients who may have concerns about their appearance. These folds serve as a second layer of protection for the vaginal and urethral openings. The labia minora meet anteriorly, where they split to form two smaller folds. The upper fold forms the prepuce, or hood, which covers the glands of the clitoris. The lower fold forms the frenulum of the clitoris. This arrangement provides protection for the highly sensitive clitoris. Posteriorly, the labia minora are either separate or may join together to form a small fold of skin called the fourchette. This entire structure frames a crucial area known as the vestibule, which we will discuss in a later section. The rich vascularity of the labia minora gives them their pinkish color and allows them to become engorged with blood during sexual arousal. Functionally, the labia minora play a role in both protection and sexual response. By enclosing the vestibule, they help to shield the openings of the urethra and vagina from infection and direct trauma. During sexual stimulation, the blood vessels within them swell, causing them to become more sensitive and prominent. This engorgement helps to guide the penis during intercourse and contributes to the overall sensory experience. The secretions from the sebaceous glands within the labia minora also contribute to lubrication, reducing friction and enhancing comfort. Their delicate nature, however, also makes them susceptible to irritation and injury. From a clinical standpoint, the labia minora are significant. They can be affected by conditions like vulvitis, which is inflammation of the vulva, often caused by infections or irritants. Small, painless cysts can sometimes develop in the sebaceous glands here. During childbirth, lacerations of the labia minora can occur. Furthermore, procedures like labiaplasty, a cosmetic surgery to alter their size or shape, are becoming more common. As a healthcare provider, you must be prepared to discuss these topics with sensitivity and provide accurate information based on a solid anatomical foundation. Understanding their structure is key to managing these clinical scenarios effectively. At the anterior junction of the labia minora lies the clitoris, a structure of immense importance for sexual function. The clitoris is the female homologue to the male penis, meaning it develops from the same embryonic tissue. However, unlike the penis, its primary function is not related to reproduction or urination. It is uniquely dedicated to sensory input and sexual pleasure. Only a small portion of the clitoris, the glans, is externally visible. The glans is a small, pea-sized nub of tissue located where the labia minora meet at the top. It is typically covered and protected by the clitoral hood, or prepuce, which is formed by the upper folds of the labia minora. The visible glans is just the tip of a much larger, complex structure. The full clitoris extends internally, deep within the pelvic tissues. It consists of a body, or shaft, and two crura, or legs, that extend downwards and outwards, anchoring to the pubic bone. The body of the clitoris contains two columns of erectile tissue called the corpora cavernosa, the same type of tissue found in the penis. During sexual arousal, these corpora cavernosa fill with blood, causing the clitoris to become erect, firm, and more sensitive. This engorgement makes the entire structure more prominent and responsive to stimulation. The most remarkable feature of the clitoris is its incredibly dense nerve supply. The glans clitoris alone contains thousands of nerve endings, far more than the glans of the penis, making it the most sensitive erogenous zone in the female body. This rich innervation is entirely dedicated to transmitting pleasurable sensations to the brain, which is crucial for triggering orgasm. The primary nerve responsible for this is the dorsal nerve of the clitoris, a branch of the pudendal nerve. Understanding this anatomy is fundamental to appreciating the physiology of the female sexual response, a topic of great importance in sexual health counseling and medicine. Clinically, the clitoris is a structure that requires careful consideration. Although it is well protected, it can be subject to injury, albeit rarely. Conditions like clitoromegaly, or enlargement of the clitoris, can be a sign of underlying endocrine disorders, such as congenital adrenal hyperplasia or exposure to androgens. Adhesions can sometimes form between the clitoral hood and the glands, which can cause pain or reduce sensation and may require a minor procedure to resolve. Any surgical procedure in the vulvar region, such as for cancer or trauma, must be performed with extreme care to avoid damaging the nerves and blood vessels that supply this vital organ. The vestibule is the smooth, almond-shaped area enclosed by the labia minora. Think of it as a small antechamber or entrance hall. It is a space of immense functional importance, as it contains the openings to two vital systems, the urinary system and the reproductive system. Specifically, within the vestibule, you will find the external urethral orifice, which is the opening of the urethra, and the vaginal orifice, which is the opening of the vagina. The tissue of the vestibule is a delicate mucous membrane, and it's kept moist by the secretions from several small glands. Understanding the layout of this area is essential for procedures like urinary catheterization and gynecological examinations. The external urethral orifice is the first opening you encounter within the vestibule, located just below the clitoris. This is the exit point for urine from the bladder. It typically appears as a small, slit-like opening. Just on either side of the urethral opening are the tiny ducts of the Skene's glands, which we will discuss later. The location of the urethral orifice, in close proximity to both the vagina and the anus, is clinically significant. It helps to explain why women are more susceptible to urinary tract infections, or UTIs, as bacteria can more easily travel from these areas into the urethra. Posterior to the urethral orifice is the larger vaginal orifice, which is the external opening to the vagina. In individuals who have not had sexual intercourse, this opening may be partially covered by a thin membrane of tissue called the hymen. The hymen can vary greatly in thickness and elasticity. It can be stretched or torn through various activities, not just intercourse, but also things like strenuous exercise or tampon use. Its presence or absence is not a reliable indicator of virginity, and that's a crucial fact for patient education. The vaginal orifice is the entry point for intercourse and the exit point during childbirth. The vestibule itself can be a site of clinical issues. A condition known as vulvar vestibulitis, or more accurately localized provoked vestibulodynia, is a chronic pain syndrome characterized by severe pain upon touch or pressure to the vestibular area. This can make intercourse, tampon insertion, or even sitting for long periods incredibly painful. The cause is not fully understood but is thought to involve nerve proliferation and inflammation. Accurate diagnosis requires a careful examination and a precise understanding of vestibular anatomy, distinguishing it from more generalized vulvar pain. This really highlights why a detailed anatomical map is so critical for clinicians. The vulvar region is equipped with several glands that are crucial for lubrication and maintaining tissue health. The most significant of these are the Bartholin's glands and the Skene's glands. Let's start with the Bartholin's glands, also known as the greater vestibular glands. There are two of them, each about the size of a pea. They are located deep in the tissue on either side of the posterior part of the vaginal opening. You cannot see or feel them during a routine examination unless they are swollen or a cyst has formed. They are the female equivalent of the bulbourethral glands in males. The primary function of the Bartholin's glands is to produce a mucus-like fluid that provides lubrication during sexual arousal. Each gland has a small duct, about 2 centimeters long, that opens onto the surface of the vestibule, in the groove between the hymen and the labia minora. When a woman is sexually stimulated, these glands secrete a few drops of clear, alkaline fluid. This secretion helps to lubricate the vaginal entrance, reducing friction and facilitating comfortable intercourse. While they contribute to lubrication, it's important to note that the bulk of lubrication during arousal comes from fluid that seeps through the vaginal walls, a process called transudation. Clinically, the Bartholin's glands are well known because their ducts can become blocked. When the duct is obstructed, the fluid backs up, causing the gland to swell and form a painless lump known as a Bartholin cyst. These cysts are relatively common and can range in size from a small pea to a golf ball. If the fluid within the cyst becomes infected with bacteria, it can lead to a painful pus-filled swelling called a Bartholin's abscess. This condition often requires medical intervention, such as drainage of the abscess and sometimes a course of antibiotics. Now, let's turn to the Skene's glands, also called the lesser vestibular glands or paraurethral glands. These are located on the anterior wall of the vagina, surrounding the lower end of the urethra. Their ducts open onto the surface of the vestibule, typically on either side of the external urethral orifice. These glands are the female homologue of the male prostate gland. They produce a fluid that is believed to have antimicrobial properties, potentially helping to protect the urinary tract from infection. Some researchers also link the Skene's glands to the phenomenon of female ejaculation, though this is still an area of active study. Inflammation or infection of these glands, known as skenitis, can cause pain and discomfort. Like any part of the body, the vulva has a rich and complex blood supply to provide oxygen and nutrients and to remove waste products. The arterial supply to this region is robust, which is essential for its function in sexual response and for healing after trauma, such as childbirth. The main blood supply to the female external genitalia comes from branches of the internal pudendal artery. This artery is a major branch of the internal iliac artery, which is one of the large vessels supplying the pelvis. Understanding this vascular map is critical for any surgeon operating in this area to avoid excessive bleeding. The internal pudendal artery gives off several important branches as it travels towards the vulva. The first major branch is the perineal artery, which supplies the superficial tissues of the perineum and the posterior aspect of the labia majora. The main trunk of the internal pudendal artery then continues forward and divides into two terminal branches, the dorsal artery of the clitoris and the deep artery of the clitoris. These two arteries are responsible for supplying the clitoris, providing the blood flow necessary for its engorgement and erection during sexual arousal. Additional blood supply to the anterior part of the labia comes from the external pudendal artery, a branch of the femoral artery. The venous drainage, which is the system of veins that carries deoxygenated blood away from the region, largely mirrors the arterial supply. The veins of the clitoris and vestibule form a large network, or plexus. This plexus drains into the internal pudendal vein, which then travels alongside the internal pudendal artery and eventually drains into the internal iliac vein. This extensive network of veins is what allows for the rapid engorgement of the erectile tissues during arousal and their subsequent detumescence. This rich vascularity also means that injuries to the vulva, such as lacerations or blunt trauma, can result in significant bleeding and the formation of large hematomas, or collections of blood. Knowledge of this vascular anatomy is paramount in a clinical setting. For instance, in cases of postpartum hemorrhage originating from vulvar or perineal tears, a clinician must know precisely where to apply pressure or place sutures to control the bleeding. Surgical procedures in this area, from a simple biopsy to a complex vulvectomy for cancer, demand a meticulous approach to identify, ligate, and preserve these vessels. Conditions like vulvar varicosities, that's varicose veins on the vulva, which can occur during pregnancy due to increased pressure on the pelvic veins, also relate directly to this venous anatomy. A firm grasp of this vascular system is non-negotiable for safe and effective practice. The nerve supply to the vulva is exceptionally rich and complex, which accounts for its high degree of sensitivity. Sensation in this region is diverse, including touch, pressure, temperature, pain, and, most notably, the specialized sensations associated with sexual pleasure. The primary nerve, responsible for innervating the majority of the external genitalia, is the pudendal nerve. This major nerve originates from the sacral plexus, specifically from the spinal nerve roots S2, S3, and S4. Its pathway is intricate, looping around ligaments in the pelvis before branching out to supply the perineum and external genitalia. The pudendal nerve gives rise to several crucial branches. The first is the inferior rectal nerve, which supplies the external anal sphincter and the skin around the anus. The next branch is the perineal nerve, which further divides into superficial branches that provide sensation to the skin of the labia majora and labia minora, and deep branches that supply the muscles of the perineum. The final and most important terminal branch is the dorsal nerve of the clitoris. This nerve is entirely sensory and travels along the shaft of the clitoris to provide the incredibly dense innervation to the glands, making it the epicenter of sexual sensation. While the pudendal nerve is the main player, it is not the only source of innervation. The anterior portions of the vulva, including the Mons pubis and the anterior labia majora, receive sensory fibers from other nerves. These include the ilioinguinal nerve and the genital branch of the genitofemoral nerve, both of which originate higher up from the lumbar plexus, specifically the L1 and L2 spinal nerves. This dual supply from different nerve plexuses is an important anatomical detail. It means that a nerve block targeting only the pudendal nerve might not completely anesthetize the entire vulva, which is a key consideration for surgical procedures. The clinical relevance of this neural anatomy is vast. Pudendal nerve entrapment, a condition where the nerve is compressed along its path, can cause chronic perineal pain, numbness, and sexual dysfunction. Diagnosing it requires a deep understanding of the nerve's course. During childbirth, a pudendal nerve block is a common anesthetic procedure used to numb the perineum and lower vagina, to relieve pain during delivery, and to allow for episiotomy and repair. To perform this block safely and effectively, the practitioner must know the precise anatomical landmarks to locate the nerve. Understanding this network is fundamental to managing pain and preserving function in this sensitive region. We have now journeyed through the intricate anatomy of the female external genitalia. The purpose of this detailed exploration goes far beyond academic exercise. It is the bedrock of clinical practice. Every structure, every vessel, and every nerve has direct relevance to patient health and the care you will provide. A superficial understanding is simply not enough. Whether you are diagnosing a simple yeast infection, managing the trauma of childbirth, or consulting on sexual dysfunction, your effectiveness hinges on a deep and confident command of this anatomy. Let us summarize why this knowledge is so indispensable. First, consider diagnostics. A patient may present with a vague complaint of discomfort down there. It is your anatomical knowledge that allows you to conduct a systematic examination to differentiate between inflammation of the labia minora, which is vulvitis, a blocked Bartholin's gland, or pain localized to the vestibule. That's vestibulodynia. Without a clear mental map of the region, symptoms can be misinterpreted, and diagnoses can be missed or delayed. Knowing the normal variations in anatomy, such as the size and shape of the labia minora, is also crucial for reassuring patients and avoiding unnecessary medical interventions. Second, think about procedures. Simple interventions like inserting a urinary catheter require you to accurately identify the urethral meatus within the vestibule, distinguishing it from the vaginal orifice. More complex procedures, like repairing a perineal tear after childbirth, demand a precise understanding of the muscle layers, blood vessels, and nerves to ensure proper healing and prevent long-term complications like incontinence or chronic pain. Performing a pudendal nerve block requires you to locate a specific nerve based on bony landmarks. In every case, anatomical precision is the key to procedural success and patient safety. Finally, this knowledge is fundamental to patient education and communication. Discussing topics related to sexual health, hygiene, and contraception requires you to use clear and accurate language. When a patient has concerns about a lump, a pain, or their appearance, you can provide confident, evidence-based reassurance and explanation. You can demystify their bodies for them, empowering them to be active participants in their own health. This builds trust and rapport, which are the cornerstones of any successful patient-provider relationship. I encourage you to revisit this topic often, using anatomical atlases and clinical resources to solidify your understanding. Mastering this anatomy is a vital step on your path to becoming an exceptional healthcare professional.